Hello. This health promotion project is being presented to you to help you learn or improve your knowledge regarding ABGs. Arterial blood gases are data collected from one blood sample. It incorporates 6 values into one test. The data from the sample tells us about oxygenation, ventilation, and the metabolic state of the patient. The reason ABGs are important to PACU nurses is because PACU is all about breathing and respiration. Knowing this will help you to advance yourself professionally, and it will help you to be able to be proactive in taking care of your patient. It will give you the knowledge to care for your patient in the best way possible. So the 3 main objectives for this presentation are that you will learn the proper method of sample collection, as ABGs are a test that are especially sensitive to pre-analytic errors. The other thing would be that you would learn the basics of ABG interpretation and learn some interventions to help correct acid-base imbalances. This will help you to also be able to anticipate orders that the physician might be going to implement. Before we can interpret any blood gases, we need to get an arterial blood sample. You can obtain that through an arterial line, or you can get it from a peripheral stick. Some of the most common pre-analytic errors would be having dilution caused by the flush solution in an arterial line, having a mixture of venous and arterial blood, and that happens when you don't hit an artery. Air bubbles in the sample. After you draw the sample, you need to inspect it and purge it of any air bubbles. Inefficient mixing with heparin. After you draw the sample, you need to roll the syringe between the palms of your hands gently to mix the heparin in the blood. When you get hemolysis of blood cells, usually it's due to the blood not pumping into the syringe fast enough, or because you're in a vein. Delay in processing, and you need to know that you only have 30 minutes to get it to the lab and have it analyzed. Again, in the PACU, we have a lot of arterial lines, and that's mostly the way that we obtain our arterial samples. One of the most common pre-analytic errors is having too much flush solution in the tubing before you draw your sample. If you're obtaining a sample with a peripheral stick, you need to make sure that you're obtaining arterial blood. The arterial blood will be bright red in color, and it will pump into the syringe fast. If it takes too long, most likely it's venous, and also you're going to have hemolysis. One thing you need to do if you're getting a peripheral blood sample is always perform a modified Allen's test. This is to ensure that the ulnar artery is functioning properly, just in case there's damage done to the radial artery. This slide tells you the steps for the modified Allen's test. We're going to practice this with each other. What you need to do is have your patient clench his or her fist, then occlude both the radial and ulnar arteries with your fingers. While you're occluding the arteries, have the patient slowly open his hand, and his palm and fingers should look blanched. Then release pressure from the ulnar artery, and you should see the fingers and the palm pink up and look flush within 5 to 15 seconds. With a positive Allen test, the hand will flush. A negative Allen test, the hand does not flush and stays blanched. What this means is that the ulnar artery is not functioning correctly, and if you were to damage the radial artery, the person would not have any circulation to their hand. So if that happens, don't puncture the radial artery. Now I have a couple of questions for you. What is the purpose of the modified Allen's test? And can you name 3 possible pre-analytic errors? The main values that we look at when we're going to interpret an arterial blood gas are the pH, which is the acid-base content, the PaCO2, which is the partial pressure of carbon dioxide, and the HCO3, which is bicarbonate. As you can see from the scale to the right, deviation from the normal values can have severe consequences. This is a list of normal values for ABGs. If you'll notice, the first 2 numbers are 3545. That makes it easy to remember those 2 values. The main ones that you need to remember for this presentation are the 3 top numbers, because those are the ones that we're mainly going to be talking about. Now for the answers. The modified Allen's test is used to test ulnar perfusion prior to puncturing the radial artery. The other question, dilution caused by flush solution, air bubbles in the sample, hemolysis of blood cells, a mixed sample, inefficient mixing of heparin, or a delay in analysis. So ABG interpretation is really not as complicated as you would think. In fact, it can be kind of fun. So try to think of it as a game. So the first step in interpreting ABGs is always to look at the pH first. This determines if your patient is acidotic or alkalotic. The pH normal, 7.35 to 7.45. This will be normal if the patient is not having any problems, or it can be normal if the patient is compensating for one of the other imbalances. If it's less than the normal, it's acidotic. Greater than normal, it's alkalotic. The next step would be to look at the PaCO2. This determines if the imbalance is caused by a respiratory effect. The normal PaCO2, 35 to 45, again, very similar to pH, normal. If it's less than 35, the patient is alkalotic, which could mean they're blowing off too much CO2, or they're compensating for a metabolic acidosis. If the PaCO2 is greater than 45, they're acidotic, which means they're retaining CO2, or they could be compensating for a metabolic alkalosis. The third step in analyzing ABGs would be to look at the bicarbonate level. This determines the metabolic effect. Your bicarbonate normal is 23 to 33, and this will be normal if the person's not having any issues or if they're compensating. If you'll notice, the bicarbonate level is the same as a serum CO2. The next time you do an ABG, compare those 2 values and you'll see they're the same. If you have an electrolyte panel, you know what your bicarbonate is. If your bicarb is less than 23, the patient is in metabolic acidosis. If it's greater than 33, the patient is in metabolic alkalosis. The body is always trying to maintain homeostasis, and that's what this acid-base balance system is all about. By the way, what are the normal ranges for the 3 main values of an ABG? So again, you're going to ask yourself, is the pH normal or is the pH abnormal? Remember, the PaCO2 is reflecting respiratory effects. Is it high or is it low? If it's high, it's respiratory acidosis. If it's low, it's respiratory alkalosis. So the answer to the last question is the the pH, which is 7.35 to 7.45, PCO2, which is 35 to 45, and bicarbonate, which is 23 to 33. The HCO3 or bicarbonate is controlled by the kidneys, and that's the metabolic effect. You need to look at this. Is it high or is it low? If it's high, it's metabolic alkalosis. If it's low, it's metabolic acidosis. The last step that you do in interpreting ABGs would be to look at whether the patient is compensating or not. If the patient is compensating, what you'll see is a normal pH with an abnormal PCO2 or HCO3. That means either the lungs or the kidneys are trying to correct the acid-base imbalance. Keep in mind that the respiratory system, it is fast. If it's trying to maintain homeostasis, it quickly either increases or decreases respiratory rate in order to correct the imbalance. The metabolic system, though, the kidneys, are very slow, and the kidneys will start to alter production to correct the acid-base imbalance. Now I'm going to mention some of the causes of imbalances of the acid-base system. Respiratory acidosis, your pH is low, your PaCO2 is high. Pretty much anything that decreases respirations causes respiratory acidosis. Hypoventilation, aspirations, sedatives, ARDS, sleep apnea. With respiratory alkalosis, your pH is high, your PaCO2 is low, and this is caused by blowing off too much CO2. It can be caused by hyperventilation, anxiety, hypoxemia, fever, or infection. When you have a metabolic acidosis, your pH is low, your bicarb is low also, and the cause of this is a loss of bicarbonate. Loss of bicarbonate can occur with diarrhea, some drugs or toxins, sepsis, DKA is a big one, and renal failure. Metabolic alkalosis, your pH is high, your bicarb is high. This is caused by excess bicarbonate produced by the kidneys. This could be caused by Cushing syndrome, hypokalemia, diuretic and corticosteroid usage, vomiting, and dehydration. Here's another question for you. What does HCO3 stand for, and what is its significance in the interpretation of ABGs? What organ regulates HCO3? Now we're going to try to put it all together. In the following situations, I want you to identify the diagnosis and any interventions that would be appropriate for the condition. HCO3 stands for bicarbonate, and it reflects the metabolic status. The kidneys regulate bicarbonate production to try to maintain homeostasis. Your patient has a diagnosis of heroin overdose. His breathing is shallow and slow. ABG results 7.30 for a pH. PaCO2 is 55. Bicarbonate is 27. This patient is retaining CO2 because his breathing is shallow and slow. So he's in acute respiratory acidosis. We see a lot of this in the PACU, as you well know. The potential treatments would be to stimulate your patient to breathe, or BiPAP or a ventilator, and then treat the cause. This next patient, 77 years old, anxiety, psychosomatic origin, rapid breathing, and slurred speech. His ABGs are 7.57, PaCO2 is 23, and bicarbonate is 21. The answer to this question is acute respiratory alkalosis. This patient is blowing off too much CO2, so you need to slow down the breathing, do the classic paper bag breathing. We don't do a lot of that. Usually it's anxiety, and you can use sedatives. And then, of course, treat the cause. This patient has a diagnosis of DKA. Blood sugar is 780, and he has an insulin drip running already. He's received 1 amp of bicarbonate. His ABG results are pH of 7.33, PaCO2 is 25, bicarbonate is 12, and PaO2 is 89. This patient is in metabolic acidosis, most likely caused by his DKA. So the big thing is treat the cause. Give bicarbonate. The patient might need dialysis for renal failure. This patient is an 80-year-old with heart disease. He's on diuretics. If you study his ABGs, you'll notice that his pH is high, bicarb is high. He is reabsorbing too much bicarbonate, and he's excreting too many electrolytes. If you were to see his electrolyte panel, his potassium level would probably be very low. Again, with metabolic alkalosis, you're going to treat the cause, increase respirations, and correct electrolyte abnormalities. This last case is a 40-year-old woman. She presented to the ER with shortness of breath, cyanotic lips. She's been had a productive cough for 2 weeks. Her temperature is elevated, her heart rate is elevated, respiratory rate is elevated, breathing rapid and shallow, breath sounds are diminished. She's got a chest x-ray that indicates bilateral pneumonia. These are her ABG results. Based on these, what would you say is going on? Her pH is normal, but it's high normal. PaCO2 is low, PaO2 is low. What does this look like? She's in compensated respiratory alkalosis. So her pH is normal because she's had 2 weeks to compensate for this respiratory alkalosis. She's very sick. She has ARDS, pneumonia, and she's been hyperventilating in order to try to compensate for the alkalosis. And she's very sick. So if you improve this lady's PaO2 by giving oxygen, her respiratory rate will probably normalize because she can relax and breathe slower. You might need to intubate or use a BiPAP. She definitely needs antibiotics and some steroids maybe, and definitely chest physiotherapy. So in order to keep track of how we're all doing with ABG collection, interpretation, we're going to keep a logbook on the unit, and this will also keep track of some statistics for us if we need them. It helps us to identify educational supplementation that's needed. There's a column in it that you'll be able to evaluate yourself, and then you can request help if you need it. The other thing that this will do is enable us to recognize our success. This is just a copy of the logbook that we're going to keep on the unit. You record the date, the patient ID, diagnosis, the reason for the ABG. Was it routine, or was it an emergent situation? Was the intervention initiated by the RN, or was it the doctor? And then there's a column for your self-evaluation. So the main thing to take away from this presentation is to be sure that you do remember the proper techniques for collecting ABGs, know how to interpret ABGs, because this is a vital piece of knowledge that every PACU nurse needs to have. It's very important for you to know the interventions needed to correct acid-base imbalances. I know that was a lot of information to take in, so if you have any questions, I'll be happy to try to answer them for you. And then afterwards we're going to have a written evaluation just to see how much you remember.